Hi everybody, and thank you for joining me in this short video presentation regarding the ECG exercise number 12. I hope you enjoy this video and join me in my future short video presentations. Thank you. The patient is a 38-year-old woman with frequent therapy-refractory highly symptomatic PVCs from outflow tract who was referred to our center for catheter ablation. Cardiac MRI showed normal ejection fraction and no late gadolinium enhancement. The baseline ECG showed frequent PVCs, and a closer look at the PVC morphology suggests an origin most probably from left ventricular outflow tract, actually the left coronary cusp. So the first point is the location of ECG electrodes, of course, which were standard and correct in this case. The so-called fat R wave in V1 and V2 and the negative QRS in 1 suggest an origin from the left coronary cusp. Even if we ignore these findings, among 5 different criteria for differentiating left from right outflow tract PVCs in patients with RS transition between V2 and V3, the last 3 also suggest the same origin for the clinical PVC. The blue color shows the earliest point in left coronary cusp. At this location, ablation was temporarily successful with early recurrence. Surprisingly, mapping of LVOT showed the earliest point on the right side, and ablation on this location, which is shown in green, was successful. The distance between 2 points was around 15 mm. The best pace mapping score in left and right outflow tract were 93 and 96% respectively, as we see here. During EPS study, a regular supraventricular tachycardia compatible with the diagnosis of typical AVNRT was induced and then successfully ablated. At faster cycle length, the AVNRT showed aberrant conduction with right bundle branch block pattern. Once again, thank you for joining me, and I hope to having you here in my future short video presentations.